This video is on Marfan syndrome. Recently, in the previous video, I talked about the ciliary zonules, so applied anatomy of the ciliary zonule composition as I made up of the fibrillary. I'm going to talk about the Marfan syndrome, and I'm going to talk about the Marfan syndrome from the book Albert Jakobiec. Okay, it's volume 4, third edition, page number 4502. Disorders of fibrillary. Marfan syndrome. Marfan syndrome is a disorder of elastic tissue with ocular, cardiovascular, and musculoskeletal manifestations. Clinical expression of Marfan syndrome is variable, with the diagnosis being made in infancy for some patients, but not until early adulthood for others. The typical Marfan appearance is secondary to skeletal abnormalities, which include increased height, disproportionality long limbs and digits, arachnodactyly, anterior chest deformity, joint laxity, vertebral column deformity, scoliosis and thoracic lordosis, and narrow, highly arched palate. Cardiovascular manifestations account for the decreased life expectancy of patients with Marfan syndrome. Dilatation of the aortic root is associated with life-threatening complications of aortic regurgitation, dissection and rupture. Treatment with beta blockers, annual echocardiograms, and improved cardiovascular surgery has reduced mortality from these problems. Mitral valve prolapse and mitral regurgitation are also found with increased frequency compared with people who do not have Marfan syndrome. Another common manifestation of clinical importance is pulmonary blebs with a predisposition to spontaneous pneumothorax. The ocular findings in patients with Marfan syndrome consist primarily of increased axial length associated with myopia and retinal detachment, corneal flatness, and ectopia lentis. The increased axial length is thought to be due to scleral stretching. Although staphylomas are generally not observed, the sclera and choroid may be thin in some patients. Dislocation of the lens occurs in 60 to 80% of patients. The most common direction and displacement is superiotemporal. Although dislocation can occur in any direction, the lens dislocation is usually not progressive, although complete dislocation of the lens can occur. As alluded to earlier, ectopia lentis in Marfan syndrome is due to abnormalities in the zonules. Good vision can be maintained in the presence of lens dislocation if amblyopia is avoided. Thus, repeated refractions are indicated for children with Marfan syndrome. Removal of the subluxated lens is not usually required and may be associated with complications such as glaucoma and retinal detachment. Lens extraction may be indicated in cases of decreased vision that are not correctable by refraction, dislocation of the lens into anterior chamber, and progressing posterior subluxation. When needed, pars plana lensectomy combined with anterior vitrectomy has shown to be relatively safe and effective for both children and adults with Marfan syndrome. Retinal detachment is reported in approximately 10% of patients with Marfan syndrome, and it is clearly associated with increased axial length. Other reported ocular anomalies include abnormal development of the iris dilator muscle and hypopigmentation of the iris pigment epithelium associated with iris transillumination. We have already discussed what is iris transillumination. So, Marfan syndrome. Transillumination can be seen in Marfan syndrome. They have not given whether it's mid periphery or near the pupil image. They have not given that thing. It's estimated that Marfan syndrome affects 4 to 6 per 1 lakh people. The syndrome is inherited in an autosomal dominant fashion with the family history noted in 60 to 80% of the cases. The remaining cases are considered to be new mutations. Marfan syndrome has been shown to be caused by mutations in the fibrillin gene FBN1. Fibrillin is a major component of microfibrils, which are the structural component of the zonules of the lens and serve as substrate for elastin in the aorta and other elastic tissues. Defects in fibrillin synthesis, secretion, and function were first detected in cultured fibroblasts from patients with Marfan syndrome. Genetic linkage studies localized the Marfan gene to chromosome 15q21.1, the same location to which the fibrillin gene was mapped. Mutations in the fibrillin gene were then detected in familial and sporadic cases of Marfan syndrome. More than mutations More than 22 mutations in the fibrillin gene have been detected in individuals with Marfan syndrome, and these mutations account for most, if not all, of the mutations leading to Marfan's phenotype. Additional discussion of the ocular findings in Marfan syndrome may be found in the chapters on the pathology of the lens, systemic associations with myopia, and retinal detachments. Key features. A common feature in these syndromes is ectopia lentis. As a major component of the cellular fibrils of the lens is fibrillin, a cysteine-rich glycoprotein. Generalized skeletal, ocular, and facial abnormalities are the rule. Patterns of inheritance of the disorders of fibrillin and elastic tissue have been largely elucidated. Key features: ophthalmic manifestations of Marfan syndrome: ectopia lentis, myopia, retinal detachment, corneal flatness. Figure 330.8. Marfan syndrome. A. Completely dislocated lens, intervitreous. B. Myopic fundus with large temporal crescent. So in Marfan syndrome, there is a defect in the fibrillin gene, okay, and main ocular manifestations are ectopia lens, superior temporal dislocation, okay. Marfan, fan is superior, so superior dislocation, and it is most commonly superior temporal dislocation. There is a myopia, increased axial length. Sclera also has the elastic, okay. Scleral anatomy and composition we will see after ciliary body and lens anatomy. So first is lens dislocation, superior temporal is the most common. Then increased axial length, so myopia and retinal detachment because of that. Then corneal flatness is also there. Then we say transillumination defects of the iris and poorly developed dilator muscles, and transillumination defects of the iris because of the poor pigmentation of the pigmented epithelium of the iris. So that was all about the Marfan syndrome, and there are a few pages. I refer the index of the Marfan syndrome, and then I saw some statements from different chapters from Albert Jacobi regarding the Marfan syndrome. So Marfan syndrome and homocystinuria are the most common non-traumatic causes of ectopia lentis. Okay. Then Marfan syndrome is the most common heritable cause of lens dislocation. It is caused by mutations in the fibrillin 1 gene, FBN1 on chromosome 15q. Q is the long arm, P is the petit short arm. So chromosome 15q21.1. The defect is usually a point mutation in one of the many calcium binding domains of the fibrillin molecule, resulting in poorly formed microfibrils. The most important systemic feature is the high risk of dissecting aneurysm of the aorta. Lens subluxation may be present at birth, may appear after birth, may be stationary or may be progressive. The zonules can be easily seen stretching from the periphery of the lens across the peripheral pupillary space. The subluxated lenses may be normal in size or small with a flatter curvature of the lower half and a posterior bulge as a result of weakness or the absence of the inferior zonules. The zonular bundles may be thin, thick, or of normal caliber, but in most cases show thin and poorly aggregated zonules. Isolated ectopia lentis is also an autosomal dominant disease. Now this was about the eye. There they have started ectopia lentis description. So this was all about the Marfan syndrome from Jacobi. There are some other statements from other books, but I don't have the volume 1 of Albert Jacobi. So I didn't get the text about the Marfan syndrome that is present in the volume 1. So this is from the volume 2, 3, and for whatever I could get from the index of Albert Jacobi. So that was all about the Marfan syndrome from Albert Jacobi, mainly from volume 4, page number 4502 and 3. Okay. Some additional videos I have added which I liked on the internet about the Marfan syndrome. You can see about the Marfan's signs and symptoms and in short treatment. Thank you so much for listening to me patient. Bye. Take care.
When you were younger, did you change in your size or your length from other children?
It was very long, very, very long and thin, which was I was always very a curiosity for people. I was a very thin person, and I might have been like the length of other people, but it just made me look thinner because of the way my bone structure is.
Are your joints particularly flexible?
Yes, very flexible. That's always been a fascination of a lot of doctors.
Yeah? How far back can you go?
This is pretty much as far as I can go.
Any other fingers? How about your wrist?
I was pretty small, about between 6 and 7. My regular physician, she noticed a little murmur in my heart, and I went to a heart specialist. And from there, I went to specialist after specialist, to heart, limbs. I mean, I've seen a number of specialists. I've always been looked at all the time. I mean, I guess I'm really used to that. I've always been being in the spotlight and just being asked questions about my hands and my bone structure and stuff.
Hello, my name is Jolie de Bakker, and in the next couple of minutes I will talk to you about Marfan syndrome and how this disease is diagnosed. Marfan syndrome is a rare disorder of connective tissue affecting approximately 1 in 5 to 1 in 10,000 people. It is a multisystemic disease, meaning that it typically affects multiple organ systems. I will get back to this in a minute. Marfan syndrome is caused by genetic defects or pathogenic variants in a gene called fibrillin-1 gene. As I just mentioned, Marfan syndrome affects multiple organ systems, among which the cardiovascular organ system is very important, since cardiovascular complications will affect life expectancy of people with Marfan syndrome. The aortic root, which is the proximal part of our largest body vessel, originating at the aortic valve, will typically dilate at a much faster rate than in normal people. With increasing diameters, the risk for tears in the vessel wall called dissection increases. Aortic dissection is a very serious complication associated with high mortality and morbidity. Another typical cardiovascular manifestation of Marfan syndrome is mitral valve prolapse, where the valve between the left atrium and left ventricle is typically too thick and too mobile. Mitral valve prolapse may induce regurgitation of the valve and eventually lead to heart failure. The other cardinal organ system when it comes to diagnosing Marfan syndrome is the ocular system. Up to 60% of people with Marfan syndrome will present with luxation of the lens, again caused by weakness of tiny fibers in the eye that are supposed to keep the lenses in their place. Moderate to severe myopia or nearsightedness is another typical ocular manifestation of Marfan syndrome. Other organ systems involved in Marfan syndrome include the skeletal system, where long bone overgrowth and increased laxity of the ligaments will lead to typical facial characteristics with a long face and typical high palate, chest wall deformities, in the form of pectum excavatum, a funnel chest, or carinatum, a pigeon breast, are also typical, as are abnormal curvatures of the spine in the form of scoliosis and/or kyphosis. Limbs are typically very long in Marfan syndrome patients, leading to an increased arm span. Fingers and toes are elongated, leading to spider-like hands or arachnodactylia. Other manifestations include pneumothorax or striae or stretch marks on the skin, which are typically located at the shoulders or the lower back. In order to score these manifestations in different organ systems for diagnostic purposes, a so-called systemic score has been developed, assigning points to each manifestation, going from 3 points for arachnodactylia, 2 points for pectus carinatum, for hindfoot deformity, for radiological abnormalities of the hip bone called protrusio acetabuli, for pneumothorax, and for widening of the dural sac or dural ectasia. Finally, 1 point is assigned to the manifestations of mitral valve prolapse, an increased arm span, myopia, abnormal elbow extension, stretch marks, facial characteristics, and scoliosis and kyphosis. Pathogenic variants in the fibrillin 1 gene located on chromosome 15 have been identified as the underlying cause of Marfan syndrome more than 25 years ago. The fibrillin 1 gene encodes for the fibrillin 1 protein, which is an important component of connective tissue. Since the discovery of the gene, over 3,000 different variants have already been identified, spread throughout the gene, and nearly all patients or families harbor their own private mutation. Different types of mutation exist, the majority of which are being so-called missense variants, leading to the alteration of one amino acid for another. Other types include nonsense variants, leading to the production of a shorter version of the protein. Interpretation of variants in the gene is not always easy, and in some cases results are not conclusive, which is also why genetic testing should not be considered as a diagnostic test in Marfan syndrome. Also important to acknowledge is that it is not possible to predict the severity of the disease manifestations based on the underlying gene defect. This is reflected by the wide spectrum of disease severity even among members of the same family carrying the same mutation. The inheritance of Marfan syndrome is what we call autosomal dominant, meaning that typically an affected individual will have inherited the disease from one of his or her parents and has a 50% chance of transmitting the disease to each child. Men and women are affected equally. It should be noted that up to 1/4 of Marfan patients has a new or spontaneous mutation, meaning that it was not inherited from the parents. Based on the clinical manifestations that I mentioned, on the family history, and in some cases complemented with genetic information, rules for diagnosing Marfan syndrome have been established in the so-called revised Ghent criteria, whereby in an isolated case the diagnosis will be confirmed when an individual presents with aortic root dilatation and ectopia lentis, or an individual has aortic root dilatation and a confirmed variant in the fibrillin 1 gene, or has aortic root dilatation with a systemic score above 7, or has ectopia lentis with a pathogenic variant in the fibrillin 1 gene known to be causing aortic dilatation. In the presence of a family history, rules are slightly different and slightly milder, where ectopia lentis and a family history of Marfan syndrome, or a systemic score above 7 points and a family history of Marfan syndrome, or aortic root dilatation and a family history of Marfan syndrome, are enough to establish the diagnosis. The key message that I wanted to bring with this presentation are firstly, and importantly, that the diagnosis of Marfan syndrome relies heavily on clinical manifestations, indicating the necessity of thorough examination in a multidisciplinary setting. Second, fibrillin 1 mutations are identified in a majority of Marfan people who fulfill the diagnostic criteria for the disease. And lastly, further improvement of diagnostic and management strategies will require collaborative efforts, of which the ERN is an important initiative.
In this video, we're going to discuss Marfan syndrome, which is a pretty commonly tested disorder. And basically, Marfan syndrome is a genetic, it's autosomal dominant disorder. And the basic problem is that you have a mutation in a protein known as fibrillin. Very important to remember. And this protein is a component of blood vessels and also of ligaments, and also is in the eye. So as a result, the complications when you have a mutation in this glycoprotein, you have problems in the cardiovascular system, mainly the heart and the blood vessels. You have problems in the musculoskeletal system because the ligaments, and of course the ocular because the lens is involved. And I'll discuss what problems occur. So let's just get started, and what we'll do is we'll break it up into cardiovascular, musculoskeletal, and ocular, and so you don't get confused, so there's not too much information bombarding you. And the first thing we'll get into is symptoms. Now, the symptoms of Marfan syndrome for the cardiovascular are very classic on licensing exams. They're not really, I mean, what I'm describing is more so not necessarily a symptom, but rather an actual occurrence. And mitral valve prolapse is by far one of the most common cardiac conditions that occurs because of that mutation in that glycoprotein fibrillin. The next thing that can happen is aortic dissection, and I have a little picture here of aortic dissection to kind of explain. So this is a diagram of a blood vessel, and this points to the blood flowing. And if you notice, there's a tear in the inner wall of this blood vessel, and as a result, that tear eventually leads to this dissection, and the blood, instead of going down the lumen, it can go into that tear. So that's a nice diagram that illustrates what aortic dissection is all about. So those are the two big ones for cardiovascular. Now, when you have a mutation in the fibrillin glycoprotein, you also get musculoskeletal abnormalities, and those most classically are very, very long arm span. The arms of such individuals are very long, and generally speaking, they are taller than average people with Marfan syndrome. Ocular, the lens is affected, the lens of the eye, and it's affected in the following way. It's dislocated lens, and it's given a special name, which is often on licensing exam is known as ectopia lentis. So those are I guess physical exam findings on tests, and more rather than symptoms. So then now, how do you diagnose it? Well, Marfan syndrome is diagnosed primarily by clinical criteria. You know, if a person comes in, they're very tall, and you're able to notice some pretty classic physical exam abnormalities. Mitral valve prolapse can even be detected on heart exam with a murmur or even a click. More commonly, if a person has mitral valve prolapse, they will have a systolic click. So some of the physical exam findings. But diagnostic testing can be great in helping diagnose this. So for the cardiovascular system, you do an echocardiogram. and the echocardiogram will show you the mitral valve prolapse. For the musculoskeletal system, you will do x-rays of the skeletal system, the hand, the spine, because a lot of these patients can also have scoliosis. And then for the ocular diagnosis, you would do something called a slit lamp exam, which helps you check for lens abnormalities. Okay, so those are the main players. So the treatment of Marfan syndrome, there's no magic cure. It's really treating the symptomatology, or treating the actual main diagnostic findings. You're focusing on prevention and treatment of complications. So the first medications I want to talk about are beta blockers. And beta blockers are known to lower the myocardial contractility, and that can reduce the progression of this aortic dissection. Now, as you know, beta blockers are used commonly for management of blood pressure, and they can also help prevent cardiovascular complications in Marfan syndrome. Sometimes, if the person have a serious enough case, you can also do aortic repair or valve repair to help make sure the cardiac complications don't progress. The musculoskeletal abnormalities are really helped with bracing and, if necessary, surgery. And the only other thing I wanted to really mention is because of this mitral valve prolapse, you've probably already heard of this, is that to prevent endocarditis, you give endocarditis prophylaxis with antibiotics. So bacterial endocarditis prophylaxis. And what that means is, before these types of patients go into anything that might predispose them to bacterial endocarditis, they're given antibiotics. So, for example, a dental procedure, things like that. Before a dental procedure, they'd be giving antibiotics. Most of the management of Marfan syndrome is very preventative rather than curative. As you can see, bracing for scoliosis and beta blockers for management of cardiovascular complications. Well, to close out, I'd like to talk about a couple of vignettes, and here we go. A 44-year-old man with Marfan syndrome, aortic insufficiency, and mitral regurg comes to the emergency department because of severe substernal chest pain for the past 3 hours. He describes the pain as tearing in quality and radiating to the neck. 1 week earlier, he experienced similar but less severe chest pain and treated himself with aspirin. Which of the following is most likely underlying cause for his worsening symptoms? Well, sometimes when a patient describes their pain, that can help a lot with what words they use. And the word here he's using is tearing. And tearing, the word tearing oftentimes is associated with a dissection. It might help to remember that it looks like a tear. Actually, the word tear is even there. And that's actually a nice buzzword to remember. And what's really happening with this patient is that he is having a dissection. He's undergoing a dissection. That is why this process of dissection is happening in him. That's why he's got such severe chest pain. And as a result, he's come to the ER. So the answer for this is going to be C, dissection of the aorta. The next one, a young man presents for an employment physical. He is very tall, has long fingers, and hyperflexible joints. He states that he has always been called double jointed. Which of the following disorders is associated with the symptom? Well, this is a relatively straightforward one. A lot of it is just looking down this list and saying if any of these match the very limited clinical vignette. And of course, since the presentation is about Marfan's, the answer is Marfan, but Marfan is not part of the choices. So you have to kind of think one step further. It's a classic second order question. Which of these is associated with Marfan's? Well, we just talked about this actually, dissecting aortic aneurysm, which is nicely pictured right here.